is Stuart Schlossman. I'm president and founder of MS Views and News. You see what the program is about. We are sponsored by Sandoz pharmaceutical company. Their medication is not yet on the market, but we're hoping that it will be soon. And now Dr. Aaron Boster is going to take it away. He's going to speak for about 35 minutes, and then we're going to do 35 minutes of Q&A. Thank you very much, everybody. And Dr. Boster, take it away, please.
Thank you so much, Stuart. Good evening. Hello, howdy, hi. Aaron Boster here. And as always, thank you for learning about MS with me. I'd like to start off by thanking MS Views and News for creating this opportunity for us to meet tonight. So thank you guys for that. Thank the sponsor Sandoz for making this possible. And thank you guys for taking some time out of your evening to up your game and talk about something I'm rather passionate about, which is how to kick MS in the teeth. I decided to become an MS doctor when I was 12 years old. Now, my Uncle Mark had had MS as my earliest memory. He had always had MS as I was growing up. But I remember very vividly going into my grandmother's house where my uncle lived. And my grandmother and my mother were sitting at the kitchen table and they were crying. And they weren't crying because my uncle had MS. He was in the other room watching TV where he normally hung out. They were crying out of frustration because they couldn't get a hold of their doctor. And they were scared and they didn't know what to do. And so I told my mother at age 12 that I would learn to do it better than the men that were taking care of my uncle. Now, I didn't know what I was telling my mom. I didn't know that I would be essentially bald by the time I finished my training. I didn't know that I'd finished the 27th year of school to get to where I need to be. All I knew was nobody should make my family that scared and that alone. And honestly, I've been rather mission driven. I was the weirdo in high school that said, I'm going to be a multiple sclerosis doctor when I grow up. And I've had a very directed course. It's been my goal to help energize, to empower and educate families impacted by MS. My presence on the internet is really an attempt to right a wrong. My family didn't have access to the internet or educational information. And whereas my uncle has passed on and my grandparents have passed on, I can help a different family. It's my hope that I can help your family. And so it's with that background that I'm absolutely delighted that I get to talk to you today. Now, we're going to be discussing multiple sclerosis on the lens of aging and what happens to the disease multiple sclerosis, what happens to the human being with multiple sclerosis as they get older. And I want to back up and level set our education about what the heck MS is. So in order to understand MS, we have to start by understanding the immune system. So we have a lot of different systems in our body, like the visual system that allows you to see me on screen, the auditory system for hearing, the circulatory system that pumps blood around the body. These are all the different systems in the body. The immune system is the dedicated system to fight bad guys, to keep out foreign invaders from the body. And it's the role of the immune system to tool around the human body. And if the immune system sees one of its own cells, it's like, hey, me, nice to see me. Oh, great, good seeing me today. But if the immune system sees a virus or a bacteria or a fungus or some parasite or something, it identifies it as a foreign invader. It takes a picture of it, so it keeps a copy so it never forgets that foreign invader. And it calls all its friends over and they all stomp that virus to death and clear it out of your body. So when you're told that you can't get chickenpox twice, that's actually false. You can get chickenpox 100 times. But the first time you get chickenpox, your immune system builds an arsenal against chickenpox. The second time you're exposed to chickenpox, your immune system has been waiting since you were 10 and it thwarts the chickenpox and you don't even manifest symptoms. So that's the way our immune system keeps the bad guys out and keeps you healthy. Now, sometimes the immune system can make an error in judgment. It can get goofed up and it can identify part of your body as a foreign invader. And that's called an autoimmune condition. Autoimmune, where the immune system is attacking yourself. There's actually a lot of autoimmune conditions out there, and I'm certain that you've heard of several of them. For example, when the immune system attacks the pancreas, then a child loses their ability to make insulin and they develop type 1 diabetes. Diabetes is an autoimmune condition. If the immune system attacks the joints, all right, of the fingers, the hands, the legs, then it can destroy those joints and cause a condition called rheumatoid arthritis. So these are all autoimmune conditions. Multiple sclerosis is an autoimmune condition, but the target is the holiest of holies, the supercomputer that runs the body, the brain. And the target are the optic nerves that run the eyes and the spinal cord, which I refer to as the superhighway, which takes the information from the brain down to the feet and then back up. And when the immune system attacks the brain and spinal cord in the setting of MS, once it makes that error in judgment, we can't undo that. We don't know how to undo that. And so for the remainder of that human being's life, as the immune system does its tour of duty looking for bad guys, and it sees your brain or your spinal cord or your optic nerve, it thinks it's looking at a virus, and it takes a picture, and it keeps the picture so it can remember, and it calls all its friends over and says, that's a bad guy, and they all stomp on it, except it is part of your brain or spinal cord. And where that attack occurs determines what kind of bad experiences the human being has. When the naughty autoreactive immune system gets into the brain or spinal cord and short circuits a part of the brain or spinal cord, the person with MS experiences an attack, a flare, an exacerbation, a relapse. Those are all the same thing. When part of the nervous system is short circuited because of inflammation from the immune response, and then that part of your body doesn't work. So God forbid that's in your left optic nerve, you're not going to see very well. You'll suffer from an optic neuritis. And then the doctors can give you steroids to hasten recovery. And if you don't fully recover, because you don't always fully recover from an attack, you can be left with some residual deficits. And neurologists, as you're probably well aware, we're pretty nerdy guys and gals, and we like to make up terminology. And so one of the made up terms that we have is called RAW, R-A-W, relapse associated worsening, when someone has an attack and they don't fully recover. So in the example of the optic neuritis, if you're completely blind and it only comes back halfway, you can see light, but you can't really read out of your eye. And so you've accrued a degree of disability from RAW. The other way that people impacted by MS can develop disability is something that we call PIRA, P-I-R-A, or progression independent from relapse activity. And this is a phenomenon where there's no attack, but the human being develops a difficulty with their neurological functions separate from attack. And a long time ago, we used to think that in the beginning of the disease, it was all relapses, and in the second half of the disease, it was all progression, and that's simply not the case. The reality is that someone with MS can experience both. And with that preamble, I want to transition our discussion to what happens as the human being celebrates birthday after birthday after birthday, and they get older. Maybe their hair starts to recede. Maybe they get a little gray here, right? As they chronologically get older, what happens to the immune system and what happens to multiple sclerosis? The average age of onset of relapsing MS is 30. And the average age of onset of primary progressive MS is 40. And most of the clinical trials that we've done studying MS medicines take people between the age of 18 and 55, which doesn't sit well because my patients are still alive and kicking at 56 and 57 and 60 and 70. So what happens to the human being as they age? So let's talk about that. I'll punctuate with a little sip of water. That's good. Okay, so the first thing that I want to discuss is how the MS phenotype changes. Phenotype is a doctor word for the outward expression of a condition, right? And so otherwise stated, the behavior of the disease multiple sclerosis changes compared to a 30-year-old as compared to a 60-year-old. As you age, the way the disease manifests can change. And it's not a discrete attacks in the beginning and relapse or progression in the end, but what we see is that acute bouts of inflammation, so attacks in MRI spots, enhancing lesions, are largely a function of age. Younger people with MS are at a higher risk to develop relapses compared to someone who's older. So if you take a group of 30-year-olds with MS and a group of 60-year-olds with MS, the 30-year-olds are more likely to suffer from an attack statistically compared to the 60-year-olds. Both groups, 30 and 60, are at risk of PIRA, progression independent from relapse activity. And that can happen as early in MS as you care to look, but it's more likely to happen as you age. So again, the group of 30-year-olds will have some PIRA, but the group of 60-year-olds will have a lot more. And so the disease phenotype changes over time, where patients will have less frequent attacks. Sometimes they stop having attacks, and they will have more PIRA, or they will accrue more disability independent from an attack as they age. When we image people impacted by MS, particularly in children with MS and young people with MS into their 20s and 30s, the disease on the MRI can be very, very active. You can see lots of lesions popping up all over the place. Now, as the human being gets older, the likelihood of a new enhancing lesion goes down, and the likelihood of brain volume loss, shrinkage, goes up. And my point here is the disease in your 20s and 30s doesn't look the same. It's not the same condition as the disease in your, say, 60s and 70s. Before we leave this topic, there's another thing that I think is critically important to understand as it relates to MS and as it relates to aging, and that has to do with the concept of functional reserve. Now, functional reserve is a very, very important concept, and it's really a way of saying, how does your nervous system deal with an insult? Now, I don't mean an insult like you're ugly. I mean an insult like you didn't sleep last night, or you have to have a surgery, or you have an infection, or it's during the menstrual cycle, or there's a very serious psychosocial situation, like God forbid the house is burning down. In those scenarios, your nervous system has to grapple with that, and the more functional reserve, the better you can handle it. Functional reserve, as you're probably not surprised to hear, is a function of age largely. And it helps me explain functional reserve, because when I was 18, I could skip a night of sleep and I didn't care. I just slept the next night and I thought that was funny. As I rapidly approach 50 years of age, I'm exhausted sharing that with you. And I try to sneak up to go to bed around 9 o'clock and hope that my family doesn't give me a hard time. Why? My functional reserve is not what it used to be as I age. In the setting of multiple sclerosis, the person's functional reserve is smaller than it used to be, and it gets smaller much, much faster than people without multiple sclerosis. And this brings me to a very, very important point. Someone with MS who has reached the 6th decade or 7th decade of life, so someone who's in their 70s, let's say, they're less statistically likely to have an attack, but they're also less statistically likely to rebound and recover. So they're still at risk of having attacks, although statistically less frequently, but when they have an attack, it's normally pretty severe and they don't bounce back. Moreover, when someone with MS who has reached 60 or 70 has a different kind of insult, like let's say that they have a horrible COVID pneumonia and they're admitted into the intensive care unit, or they have to have a major heart surgery or something serious like this, sometimes they come out of that experience neurologically doing less well than before they went in. And that has everything to do with their functional reserve being smaller as they age. So as we think about the way that MS changes over time, I want you to keep in mind, you're still at risk of attack, but you're less likely to have an attack. You're less likely to bounce back if you have an attack. You're less likely to have new contrast enhancing lesions, and you're more likely to have shrinkage on the MRI. You have an increased risk of accruing disability independent from attack, and your functional reserve is dropping. And these are some of the realities of the changes that we see in MS as the individual human ages. Now, multiple sclerosis is a very complex disease, and it's not just the interplay of the immune system and the nervous system. There's other factors which play a role in MS and play a role in aging in MS. And one of the ones that I would like to highlight today is the endocrine system. So the endocrine system is a system of hormones. Hormones are chemicals released in one part of the body. They have an effect somewhere else in the body, and they can help regulate all kinds of different things. And in specific, I want to talk about the hormonal changes that we see in both men and women as they age. So we'll start talking about men, simply because it's a bit of a shorter conversation. And as gentlemen age, our testosterone levels can drop. And so, you know, when you measure testosterone in a virile 20-year-old, you may see a value like 800 or like 1,000. They have a really high testosterone level at that age. As we age, our testosterone levels can fall, and they can fall a lot. And in my clinical practice at the Boster Center for MS, where I care for patients and families here in Ohio, we check testosterone levels in men once or twice a year. And what I routinely find in guys who are in their 50s and 60s and 70s and older is we have really low testosterone levels. Now, it turns out that testosterone correlates with some very important features in the setting of having MS. Low levels of testosterone in men with MS correlate with some very significant problems. So I'm not just talking about the bedroom. Yes, low levels of testosterone can make it difficult to obtain or maintain an erection, right? And so whenever I'm working someone up for sexual dysfunction, I'm always checking a guy's testosterone. But it goes way beyond that, because it turns out that low levels of testosterone in MS drive disability faster. You literally get worse faster if your testosterone is low. And it can have a major impact on fatigue. Fatigue gets worse when your testosterone is low. And it can have a major impact on cognition. Cognition goes down when testosterone is low. So to add insult to injury, here you are with MS, aging, and in addition, your testosterone is falling. And so at the Boster Center, when we check someone's testosterone level, if we find that it's low, like say below 200, then we will supplement their testosterone. We give them testosterone shots, or we give them a testosterone cream, or sometimes they can have implanted pellets by the urologist, and we drive the testosterone level back up into a normal range. Now, not the range of a 20-year-old, but into a normal range in the 500-600, like somewhere in there. And routinely, what we see is awesome sauce, because the gentleman with MS will gain more energy, more cognitive wherewithal. The bedroom works a bit better, which is lovely. But importantly, it slows down the disease process. And so I think that's very, very important. If you or someone you love is a gentleman with MS, then I absolutely recommend having a total testosterone level checked. You want to check the level in the morning, because in the morning is when you'll have the highest testosterone level. And if you're trying to get insurance to cover testosterone replacement therapy, you have to show them a low morning level, or they're going to throw the value out. So just as an FYI, that's when you want to check that test. Oftentimes, insurance companies want 2 low levels before they will agree to supplement testosterone, just as an FYI. Now we're going to shift gears and talk about women. Now, women have MS a lot more than men, like 3 times more often than men. And as women age, their endocrine system changes big time. So when a woman is around 40-ish, she will sometimes begin what's called perimenopause, where the hormones that help her develop, gestate a child are dropping. The estrogen levels start to drop in your mid-20s. The progesterone levels start to drop. And then another hormone called the anti-Müllerian hormone, it starts to drop also. And as these hormones drop, the menstrual cycle can become erratic. So instead of being once a month like clockwork, a woman may have a menstrual cycle which is spaced out, and they have a period in 6 weeks, and then 8 weeks, and they don't have one for like 2 months, and then they have a really heavy one. And during this time of perimenopause, they can develop lots and lots of very frustrating symptoms. Now, frequently, by the time you're 55-ish, women are full on in menopause. Menopause is defined as no menstrual cycle for 12 months. And in menopause, just like perimenopause, we can see a host of symptoms. Now, the symptoms I'm about to list are all menopause symptoms, right? And then we're going to tie this back into MS. So completely separate from multiple sclerosis, as a woman goes through menopause, she can develop cognitive impairment. She can have cog fog and not think clearly. She can develop worsening anxiety and very frequently worsening depression. She can develop difficulties with sleep and develop insomnia and develop very serious fatigue during the day. She can develop, of course, the hot flashes that we always associate, the vasomotor changes with menopause. She can also develop some difficulties in the bedroom and in the bathroom, where bladder control can become an issue, bowel control can become an issue, and the down theres can be affected, where we have less estrogen and therefore less adequate lubrication and sometimes more difficulty with intercourse, or a nasty term called dyspareunia, which is a Scrabble word that means that sexual sensation actually hurts, which is yucky. Importantly, there are some changes to the multiple sclerosis that we can see when a woman goes through perimenopause and menopause. And this has been well studied. Now, I want to give a shout out to a friend of mine named Riley Bouvet. Dr. Bouvet is a rock star MS neurologist out at UCSF in California. And she is one of the leaders in the field of understanding menopause with women with multiple sclerosis. And so a lot of what I'm sharing with you right now, I'm citing her work. She's a really cool lady. And what we've learned is that when a woman goes through menopause, the statistical risk of an attack goes down a little bit, which is good, but the risk of progression increases. She gets worse faster. So when you look at newly diagnosed patients with MS in their 30s, women have a slower progression of neurological disability compared to men. That's true. And we think that it may have something to do with estrogen levels, because when the estrogen levels fall and they go into menopause, the rate of progression becomes equivalent to that of a man. Now, when I was listing all of those symptoms just a little bit ago, all these menopause symptoms, it may have reminded you of many of the MS symptoms that we see in people anyways: cog fog, depression, decreased energy levels. That's what Aaron refers to as the up theres. Difficulty with bowel, bladder, sexual function. That's problems with the down theres. Fatigue, which is very common in MS. And when you think about it, it's kind of like adding insult to injury. That here we are dealing with MS and we're dealing with aging in MS, and then we add menopause on top of it. So what do we do about that? Well, it turns out that it's treatable. So one of the things that I am a big proponent of is to have you, the woman with MS going through menopause, to talk to your gynecologist about hormone replacement therapy. Now, hormone replacement therapy in the general population has fallen out of favor. Why? Because when you have estrogen and progesterone together, it increases risk of cancer, which is very serious. And oral estrogen can increase the risk of blood clots, which is also very serious. So at first blush, the OB-GYN is going to say, no, honey, let's not do that. But I have an idea. If you do estrogen only hormone replacement therapy, the risk of cancer doesn't really seemingly go up. And if you do a patch, a topical estrogen or a cream, it does not increase the risk of blood clots. And so I think that there is a path where a woman with multiple sclerosis who is now in her, let's say 40s, 50s, 60s, somewhere in there, and going through perimenopause or menopause, should have a conversation with her obstetrician gynecologist and say, hey, look, what about putting me on an estrogen topical so that we can drive the estrogen levels up? And time again, when my patients do that, I see improvements to many of the symptoms I listed. Constipation gets better, the bladder control gets better, the bedroom gets better, thinking gets better, depression gets better. And I think that's a really big deal. Now, sometimes for multitudes of reasons, that's not safe. And so then we have to kind of come up with a plan B. And so oftentimes doing something like taking a long-acting SSRI medicine like a Prozac can help with some of those symptoms, but not all. I want you to be empowered to have a conversation with your gynecologist and your neurologist and say, hey, what about doing this so you can help me out with some of my symptoms? Because I don't think we have to take it lying down. Now, I'm going to shift gears because otherwise I'm going to keep you here all night, and I want to make sure that we have time for questions. The next organ system that I want to talk, which is very relevant in the setting of MS and aging, is actually the bones. So your bones keep you upright, and they attach your muscles and they make you move around. And as we age, our bones can get thinner. And in the setting of multiple sclerosis, after the age of 50, for both men and women, independent from steroids, there's an accelerated bone thinning. And so surprisingly, sometimes we can see a 50-something with MS who has very, very brittle bones and is at high risk of fractures. Now, the two nerd words are osteopenia. Osteo means bone, penia means small. And so thinning bones. And then if it gets really bad, there's a different term called osteoporosis, where the bones have very significant thinning. And this can be a major issue in the setting of MS. People impacted by MS can sometimes be at high risk of falling. And if you have thinning bones and you fall, sometimes you can have a terrible thing happen, like a fractured leg or a busted hip. And that can be really, really bad news bears. So as someone with MS ages, one of the critical things that we need to do is we need to start to do DEXA bone density scans. I feel that it's a best practice to do a bone density scan in all people with MS after the age of 50, boys and girls. Sometimes we have to have a little battle royale with the insurance company to explain to them why we're doing it early, because in the general population, it's not generally recommended at 50, but in the MS population, it sure as hey is. And we can explain with data to the insurance company why we need to do that. And if we get a bone density test and we see that the bones are too thin, fortunately, there are medicines to beef up the bones, all right, to pack on some density and help them. There's also some other things that we can do outside of medicines. Stomping the ground helps reactive bone growth. So choosing exercises that involve, like, for example, walking or like jazzercise or something where you're pounding the ground with your feet is a great way to help maintain reactive bone growth. I also feel like it's really important that we think about what we eat, because calcium is the building block of bones. And so we want to make sure that there's adequate calcium in your diet. The vitamin D3 that your neurologist wants you to take to slow down your MS also helps push calcium into your bones. And we may sprinkle a little K2 on top of that to help further get the calcium into the bones. And so as we think about MS and aging, one of the things that we need to think about is bone health. Now, the next topic that I want to bring up is the fact that sometimes nature's too generous. My mentor used to say that all the time. And someone with MS, as they age, they can pick up what we call in medicine comorbidities. So a comorbidity is another condition in addition to the MS. And so as we age, we increase the risk, for example, of cancer. As we age, we can develop an increased risk of cardiovascular disease. We can have diabetes that can develop. We can have high blood pressure that can develop. And so this is to say that in order to live your best life despite having MS, and in order to live your best life as you age, you need a team, you need a village. And I want a general practitioner, a primary care doctor, to be a member of that team. And I really lean on that primary care doctor to make sure that we're up to date in our cancer screening, to make sure that we're up to date with our cardiovascular health and all the other things. And that's really a recipe to living your best life despite having this condition. I would like to wrap up this didactic talking about the elephant in the room. Should we continue to take disease-modifying therapies even as we get older? And as Stuart suggested as we started this program tonight, it's a really hot topic, and it's a really heated topic amongst MS neurology nerds like myself. So when we get together at big congresses, we literally have like a fight about whether or not we should continue patients on drugs or not. And there's really two camps. So there's one camp that says, hey, look, as the human being gets older, they can experience something called immunosenescence, which is a Scrabble word, which means your immune system slows down as you get older. And it looks like these disease-modifying therapies are not as effective in a 60 compared to a 30-year-old. So maybe they say that we could just take someone off their medicine when they reach a certain age, and then they're going to be okay. And I think that's BS. I'm in the other camp, and I feel very passionate about this. I feel like it's inappropriate to be ageist. And just because you celebrated your 55th or your 60th or your 65th birthday, that celebration does not equal you no longer deserve to be on a disease-modifying therapy. As I mentioned to you earlier, as you age, you're less likely to have an attack, which is good, but you're more likely not to recover, which is bad. And so taking a medicine to protect you from attacks is still very, very relevant, although for a slightly different reason. Moreover, the disease-modifying therapies that are available today do more than just prevent attacks. They slow disability. And I'll share with you a study, which I found very frustrating, where they took a bunch of 55-year-olds on MS medicines who had stable disease for 5 years. So no attacks, no new spots for 5 years. And they took them off their disease-modifying therapy and they watched them for like 2 or 3 years. And what they found was there were very few, if any, attacks. And they concluded that it's okay to stop medicine because only 1/3 of all the people studied progressed in disability. Now I want to call BS, because if that 1/3 include my mother, we're going to have some very serious words. I'm not okay with that. And because we're not smart enough to predict who's going to progress and who isn't, I think the better part of valor is to keep on keeping on. I do not believe in stopping medicine because you've celebrated a particular birthday. I think that's actually ethically wrong. I do believe in the concept of de-escalation, where as we age, we might not need as oomphy of a medicine with the same risk profile. We might be able to decelerate to, we could de-accelerate to something that works, but maybe not as well, but it has a better side effect profile. And that I think is fair. My name's Aaron Boster, and as always, thank you for learning about MS with me. Thank you for taking time out of your evening to up your game and talk about this very, very important topic. And I want to turn the mic back over to Stuart, and we can open up the lines for questions.
Here, and I want to thank you very much. Everybody, give him a round of applause. I can't hear you, but give him a round of applause anyway, because he definitely deserves it. He covered so many topics. It was great to see this. It's also fabulous to see over 100 people online again. We have not seen this for this kind. We haven't done this program in a couple of years, so I'm really happy that everybody's online. So let's start off with some questions here. Firstly, person writes spoons, and I agree with spoons, all right? This morning, for instance, I got up and I have to wear special braces on my feet because I got bad orthotics going on with my feet, not MS related. But even so, putting it on, taking it off, trying a different one, trying another one, 3 different attempts of doing it. And I just looked at my loved one and I said, I'm done for the day. I got to take a break. I'm out of spoons already, and it's 7:30 in the morning. So what happens with our spoons? I mean, you've spoken about spoon theory. Can you tell this to others, please?
I would love to. So spoon theory is a brilliant concept that was invented by a woman with lupus, which is another autoimmune disease. And whereas lupus and MS are not the same condition, they both have a hallmark of profound pathologic fatigue. And spoon theory is, in my opinion, one of the easiest ways to help friends and family understand MS fatigue. And so I talk about it in clinic a lot. The spoon is a unit of measurement. And since I'm in my house, I'm going to go get some spoons so that I can use them as a prop. So hopefully you can still hear me while I collect a bunch of spoons. All right. So when you wake up in the morning, you wake up with all the spoons you're going to have. Okay. So let's say I wake up and I have 50 spoons today, and then I'm going to take a shower. So that's going to cost me a spoon. I'm going to wake my kid up, which for me takes about 2 spoons. I'm going to make my kid some food and make him eat it, which is going to cost me a spoon. And I'm going to drive him to school because he hasn't gotten his license yet. And so I got to do that before I get to work. All right. So I'm using spoons as I go through my day. When you have multiple sclerosis and your functional reserve is small, you don't wake up with 50 spoons. You may wake up with 5 spoons. And so you still have to take a shower. I mean, I would hope. And you still have to get your kids off to school. And you still have to make breakfast. And you only got 1 spoon left. All right, it's just morning time. And your day's not over yet. And so what ends up happening is you start to tap into tomorrow's spoons, and you can end up paying the devil's price. And so I see this all the time, and I'll use a classic Ohio example. A lot of gals that I take care of here in Ohio have a sense of pride putting on a big dinner for Thanksgiving for their family. And a lot of the women I take care of refuse to allow people to help them. They're going to do it themselves the same way their mom did, right? They're going to do everything, and they can. But boy, man, they tap into tomorrow's spoons and the day after, and they put on a spread for all 20 people, and then they will spend a couple days in bed recovering, right? It's pretty serious, particularly if you don't plan for that. And so spoon theory is something that I want you to talk to your friends and family about. And I want you to get to the point where you can say, I don't have any more spoons. And they should know what that means. Now, the tenor of today's lecture is on aging. And as I was talking about a shrinking functional reserve, as you age, you have less and less spoons. Now, I don't want to end on a note. I want to talk about how you can save spoons. What I need you to do is be very, very planful. So you got your honey-do list, okay? So you got your honey-do list, and we need to do grocery shopping and go to the laundromat, and we need to prep dinner, all right? And then we have to do an errand. Those are the things on the list. And if you do all 4 things on the list, you'll get them all done, and then you'll risk spending the day in bed. So what I want you to do is I want you to look at the list and say, okay, I'm going to do the laundromat tomorrow. I'm going to do the grocery shopping and make dinner. I'm going to run the errand in 2 days. I'm going to play smarter, not harder, and I'm going to space things out so that I can adequately use my spoons. That was a great question, and thank you for asking it.
All right, person writes, are attacks on the brain or spinal cord usually together, or is it one or the other? I know that had nothing to do with today's talk, but you can ask it. I asked it anyway.
So just really quick, so attacks can oftentimes occur in one or the other location. It's not common that you have a multifocal attack. It can happen, but it's very, very unusual in the setting of MS, where you'll see a bunch of brain and a bunch of spine lesions at the exact same time.
Okay, thank you. Person writes, I'm 63 on Avonex for more than 25 years. Should I stick with it or look to switching to Mavenclad?
So I have a biased answer because Avonex, in my educated opinion, is the least effective of all the disease-modifying therapies. And its biggest weakness is it's not good at slowing disability. The disability data is crappy. So when I'm posed with a 63-year-old taking a low-dose interferon beta product or Mavenclad, I'm going to do Mavenclad for a couple reasons. Mavenclad is more effective, and I think it has better data to slow disability, which is something I'm very keen on. And Mavenclad is discontinuous. You take 10 pills the first year, 10 pills the second year, and then you don't have to keep taking something. So you could ostensibly enter into Medicare at 65 and not be on a medicine and not need another medicine. And so that's where I would place my thoughts.
Canes. Why would a person all of a sudden need a cane just because they got to be over 60 years old? Is their body actually doing less able to be functional, or is it truly from the age?
So this is a really important point because as you age, you can develop some disability just from age, right? And so if you look at a group of 65-year-old human beings, MS or not, some of them will need a cane for various reasons. And so it's a fair question to say, well, am I having this difficulty because of my MS, or am I having this difficulty for some other reason? And sometimes it's not super easy at first blush to sort out. A couple things that I want to touch on is we want to control the controllables, right? So for example, we need to commit to a lifestyle of movement and exercise so that we don't risk becoming deconditioned. I have some patients that end up picking up a cane, not because of an MS attack, but because they become so deconditioned that they're not steady on their feet. And when we send them to the neurophysical therapist, who are some of the nicest sadists that you'll ever meet, whooping them into shape, they drop the cane. And so I think someone who uses a cane is someone who's smart because they don't want to tumble. And I think that's very, very smart. But I think we have to ask the question, why do we need a cane? Is there anything that we can do to improve your mobility and maybe not even need it so much?
Okay, thank you. Let's talk about bladder issues and age. Okay, if you could just say something about that right now. I don't have to get into the question because you have plenty to say.
Bladder's a very, very common symptom in the setting of MS, and there's typically three kinds of bladder problems. There's an overactive bladder where the bladder spasms down into like the size of a racquetball, and you can hold like half a glass of water and you got to sprint to the bathroom. And so that manifests as frequency, meaning, man, I pee a lot more than all my friends and family. Urgency, like, oh God, move, I'm gonna pee, and if you don't let me in, I'm gonna pee anyways. Nocturia, which means I get up multiple times a night to pee. And sometimes accidents because you can't get there in time. Another option for MS bladder problems is called retention, where it's not so much the bag of the bladder, but the outflow tract, the urethra, is tight, and it's like a swizzle straw. It's now you're trying to push fluid through a swizzle straw and it doesn't come out. This manifests differently as you feel the sense to pee and you sit down or stand to pee and nothing happens, or just a little trickle comes out. Or you're done peeing and you stand up, I gotta sit back down and pee again. Or you have to push on your bladder to get the urine out. And sometimes that can build up and build up to the point where you'll lose all of your water, and without warning, you'll have a complete accident. And I would submit to you that whereas people impacted by MS are at risk of that, those risks might go up a bit as we age. Also for gentlemen, we have a prostate, and the prostate is a gland that's wrapped around the urethra, the outflow tract. So as we age, the prostate can grow and it can clamp down on that. So we can have more than one reason why we might suffer from retention. The friendly neighborhood urologist is awesome sauce at helping us sort out the problems. And the good news is there are a host of things that we can do to help your bladder. There's no less than 6 or 7 pills that we can try. There are procedures that can be done. We almost never have to accept a bladder that's not functioning. We can do something to keep you dry.
Thank you very much. Next, the person writes, should a PPMS patient who's 68 still stay on Ocrevus? Are there side effects? Are the side effects worth the risk?
That's a great question. So we say, okay, so I have PPMS, which means the only FDA approved drug is Ocrevus, and they're 68 years old, so they're no longer 20. And so they are at increased risk potentially by age of infection. And they're taking the MS medicine ocrelizumab, approved for PPMS, which increases the risk of infection. So let's unpack this. What do I do in that situation? Well, what I don't do is take them off because of their age, because I think that's ageist and dumb. What I do is I monitor their risk of infection 3 ways. Number 1, I ask them, have they had any infections? And so if they say, oh my God, I had pneumonia last month, I had bronchitis 2 months ago, I've been having recurrent UTIs, that's very disconcerting. And that might lead to us spacing out the infusions, or in some extreme cases, coming off the drug. There's other things that I do. I check laboratories. And the 2 labs that I check are the antibody levels, and that's the IgG level. So IgG is doctor talk for antibody. And I want to make sure that the antibody levels are not falling below 600, because if they go below 600, we increase the risk of infection. And some patients with MS on Ocrevus or any of the B-cell depleting medicines can have a lowered IgG. And so if the 68-year-old's counts go below 600, that's going to be pause. That's cause to have a conversation about potentially spacing out the infusions. Lastly, I like to check the lymphocyte count. So the ALC, or absolute lymphocyte count. And it's the same number. If it's above 600, we're good in the hood. And if it's below 600, then we're going to have a conversation. So I'll give you an example of someone I take care of with PPMS who is 80 years old, 80, and they are one of the most spry individuals I've ever met. They just retired last year. Very, very active, travel constantly, kind of a neat guy. And the counts, the lymphocyte count is really high. The antibody level is really high. No infections whatsoever. I'm going to keep treating him. But if the infections were there or the counts went lower, we might need to pause. So that was a great question. Thank you for asking.
Okay, excellent. Thank you very much. Person writes, I just turned 72 and finished Mavenclad 2nd year in June. Should I expect to be in total remission?
So words matter to me. In the definition of remission, at least my definition of remission, I borrow from oncology, from cancer. So the oncologic definition of remission that I use is 5 years with no disease activity and no treatment. So 5 years of no treatment and no disease activity. So you don't meet the oncologic definition yet of remission. But what you've done is you've taken a discontinuous therapy where you rebooted your immune system in your early 70s, and it's my sincere hope that you achieve remission over the next 5 years. Best of luck.
Okay, next. I am 53, have been on Copaxone for over 15 years with no relapses. I would like to look into a pill form DMT that is similar to Copaxone. Is there anything possible or anything that I should consider?
Yes. So a lot of this gets into like opinion, but you're stuck talking to me, so I'll give you my opinion. And a lot of times I will make a transition from a medicine like Copaxone, which is an immunomodulatory drug. It's not suppressing the immune system, it's tweaking the immune system. And I'll put them on something that's a pill, for example, Aubagio or teriflunomide, all right? So Aubagio is a once-a-day pill. It is not an immunosuppressant. It's an immunomodulatory drug. There are now generics that are being made and whatnot, and you can typically find them for relatively inexpensive. And Aubagio brings more to the table than Copaxone, in my strong opinion. Aubagio has much better brain volume data and has much better disability data than Copaxone. And it's nice to swallow a pill as opposed to like jabbing yourself with a needle 3 times a week. So I would consider Aubagio amongst other drugs.
Great, thank you for that. Does your brain atrophy as you age, and how can you relate atrophy to MS?
Yes, so as we age, we get shorter, right? So I used to be 6 feet tall and now I'm only 5'11", I'm joking, but we get shorter as we age. Our skin gets thinner as we age. Like, so there are age changes that we see in the body. The brain shrinks on purpose as we age. So after the age of 18, the brain starts to shrink, and it typically shrinks about 0.2% a year. So like 1/5% a year. And that becomes a little bit faster as we get a little bit older. In the setting of untreated MS, the brain can shrink 5 to 10 times faster than normal. And brain volume loss, shrinkage, or atrophy is one of the best correlates to long-term disability and cognitive impairment. So when you're looking at the MRI pictures and you're looking at the white spots and the enhancing spots, you also want to look at the dark spots, and you want to look at the brain volume. Now, there are some fancy pants programs that we use at the Boster Center to calculate brain volume, but you can also do a poor man's assessment where the radiologist will measure the width of the third ventricle and give you a sense. And if your brain is shrinking too quickly, I think that's something that needs to be discussed. And there are things that we can try to do to help slow the rate that the brain shrinks at.
Next, we asked, a person asked, how much shorter will life be because of MS?
So early on, when we studied this question, it looked like people impacted by MS died about 5 years earlier than the general population. And it's my opinion that that is changing with the earliest applications of the most effective medicines. It's my belief that with the earliest applications of effective medicines, we can reach a normal life expectancy and a normal life quality.
Gotcha. Okay, thank you for that. Next, I'm 45 and having more joint pain. Is this aging or progression?
MS does a lot of things, but it does not do skin and it does not do joint, or at least not directly. Okay, so let me explain what I mean by that. So MS does not impact the joints, like the immune attack is not on the joints. And so we don't see direct joint damage from multiple sclerosis. You can see indirect damage from MS. And I would give you a demonstration, but I'm wearing a pair of shorts, and so I'm only going to show you from the waist up. But if I was able to get up and walk, what I would show you, if I imitated a limp, like where the left leg is weak and you're kind of throwing the left leg forward, think about what happens to the right leg. you're bearing a bunch of weight on your right hip and your right knee in a way that it wasn't meant to be used. And after years of walking whapper-jawed, where you're having to throw your left leg forward, sometimes you can destroy or beat up on the joints of the good leg. And so sometimes we will see an arthritic condition in the good leg because of abnormal walking. Either way, get ye to your doctor and have them work you up for what's going on with your joints. And there's probably a path so that we can make them not hurt so much and function better.
Okay, next question. Does aging in general affect progression of MS?
I think I would say yes. So kind of as we were talking about at the beginning of the talk, as someone with MS gets older, the statistical likelihood of an attack goes down and the statistical likelihood of progression goes up. So I do think that you're more likely to see someone have progression of disability at an older age as compared to a younger age.
Please discuss the effects of stopping long-term meds as you reach 70 to 75 years old. I think you spoke about it before, but this question just came in.
So I'm very bothered when an MS neurologist wants to stop drug in a 50-something. That's too young. I'm very bothered when an MS doctor wants to stop a drug in a 60-something. That's too young. When someone enters into their 70s, that's when I was taught you can start to have conversations of backing off. And as I shared with you, it is not my style to stop the drug. It is instead my style to de-escalate, to take them off a drug with higher risk and put them on a drug which has a lower risk. And so that's the way that I like to approach that.
Okay, thank you. Person writes, you talk about the impacts of aging on hormones. This plus the side effects of replacements can lead to weight gain. How can we control such weight gain while aging with MS? Any value in weight loss medications?
So this is also a very hot topic. And there are these semaglutide medicines, which are injections, which have become FDA approved for obesity associated with diabetes. And they are rather remarkable in helping change brain chemistry and gut motility to help people lose weight. And it's very attractive to think, hey, I could take a shot and I could lose a bunch of weight. And that's particularly true for someone that has motor problems and they can't exercise as easily. Now, early work would suggest that semaglutide is actually safe in the setting of multiple sclerosis. It does not appear to be dangerous in the setting of MS. And there's even some theoretical discussions that it may actually help MS, but that's still a theory. I want to caution that if it sounds too good to be true, it probably is. And taking a shot semaglutide by itself to lose weight is probably not the best plan, because when you stop the semaglutide, you can gain the weight back unless you've changed your behaviors. And so using a weight loss medicine like semaglutide in conjunction with changing the way that you approach food, in conjunction with a lifestyle of exercise, is a great choice. And I see nothing wrong with that whatsoever. Just because you reach 50, 60, or 70 doesn't mean you can't lose weight, because you can.
Okay, thank you for that. Next person writes, if I've ever been on a DMT, does it make sense? Ever been on a DMT? Does it make sense to start at age 65?
Yes.
Okay, next. What kind of medications do you de-escalate to as someone ages?
So the two medicines that I reach for the most often are Mavenclad and Aubagio. And again, this is just Aaron's opinion, all right? So those are the medications that I de-escalate to most commonly. Rarely, I will de-escalate to something like a Tecfidera Vumerity. And again, this doesn't make me right, it just makes me really opinionated, but it works really well in my clinic.
Great, thank you. Next, where can I get more information on stopping DMTs or continuing them? I'm 61, I've been taking DMTs for 30 years. My MS is now progressive, and I want to make a learned decision.
So let me make a selfless plug for MS Views and News educational YouTube channel. So this organization that is sponsoring tonight has amassed the who's who in MS, giving almost like TED Talks. And so the first place I would look is on MS Fusion News YouTube learning channel, where you're going to find several MS experts talking about those topics. So that's the first place. The second place, if I may be so bold, is to look at my YouTube channel. So I have a YouTube channel called Aaron Boster MD, and I have a bunch of videos on stopping medicines or de-escalating. Most importantly, I think that's a conversation for you to have with your healthcare professional who's helping with your MS. And so having an engaged conversation with your neurologist and your neurology team, I think, is the best idea as well.
Thank you very much. And by the way, his website or his YouTube channel is the place to go. I don't look at ours. I mean, do look at ours, but definitely do look at his, all right? Okay. And in kudos to myself, a person writes, it's not that I'm giving kudos to myself. I still have a lot of questions to ask, but this person wanted me to say this. Thank you, Stuart, for such wonderful work to provide us with MS presentations. I have even more respect for you, as you also have MS. You're invested in helping those of us with multiple sclerosis. Thank you, Patricia. I am saying your name. Thank you very much. And Patricia's, a lot of people named Patricia, right? Okay, but thank you. You know who you are. All right, next person writes, you mentioned walking as a stomping exercise. In winter months, it is not really possible for me to go for walks. I'm not confident getting on a treadmill because of balance issues. Can you suggest other exercises for MS patients to reduce bone loss?
Sure. So I would challenge your comment about the treadmill, because if you have a treadmill with rails that you can hold on to and you move slow enough, you can still stomp the ground and walk. I live in sunny Ohio, where it's not remotely sunny for half the year, and we have some serious snow for some of the months, and so going out walking outside is going to not be possible. And a lot of people walk in the mall, right? So they'll go to like a mall or like a Walmart and they'll do laps, and you know, it's nice inside and it's warm, and that's a great way to do it. Another thing that you can do would be participating in some type of like group exercise, like yoga. Would not be great for stomping, but you can do some standing stuff, or doing like a group aerobic exercise. Another one, which is really, really valuable for health of bones, is weightlifting. Anything that involves holding weight on your axial skeleton, deadlifting, overhead pressing dumbbells, doing a squat, like those kind of exercises which compress the axial skeleton, can cause reactive bone growth. And you can certainly do that without walking around. Great question. Thank you.
Great. Thank you very much. Again, for those that are asking questions that have nothing to do with tonight's topic, I'm sorry, but we're not going to have enough time to get to those questions, and I am sticking to the ones that pertain to people aging, okay? Thank you. We'll do those another time. I hope to have Dr. Boster back on every other month.
I would love it. Done.
Next, we have, let's see, we have, I take Provigil long-term. It works well. I'm over 60 and I've had MS for 2 years.
So Provigil is the trade name for a drug called modafinil. And whereas it's not FDA approved for MS, I use it all the time in MS patients because it helps with fatigue and cog fog. So Provigil is what they give airline pilots when they fly across the Atlantic. And there was actually a really cool study done looking at chess grandmasters, no MS, just chess. And what they found was chess grandmasters that take Provigil win more games. And Provigil can make a profound impact for the better on staying awake and alert, and also being attentive and being able to remember better. And so I'm a big fan. The side effects of Provigil include things like high blood pressure. And so we want to make sure that we're not putting your heart at risk and that we're not causing a situation with increased blood pressure. In my experience, as long as we're keeping an eye on that, I do not think there's a reason we have to stop because of a particular age. Now, of course, this is a question which is best asked to your doctor, because we don't have enough information about you specifically to give you a particular recommendation. And so this is an absolute perfect question to ask your neurologist to make sure that the risk benefit is being balanced correctly.
How would a move to a more powerful disease-modifying therapy, such as Mavenclad, fit into senior citizen treatment strategies?
So it's my strong opinion that I want you on the most effective DMT that you're comfortable taking, right? And that comment is not based on just being 20 or 30. And so I think that we're allowed to look at higher efficacy drugs. Mavenclad is a higher efficacy drug. And there's a risk and there's a benefit to all the drugs. And as long as we're talking properly through the risk benefit of Mavenclad, I think it's on the table. I use a lot of Mavenclad in 60 and 70 something patients, a lot. And I find it to be an excellent drug in that age group. One of the things that I like about it a lot is that it transiently drops your counts and then they pop right back up. And so 4 months into treatment, you're no longer immunosuppressed. And so your immune system can fight off bad guys. And I really like that in that age group in particular.
Will Mavenclad work with a person that's over 70 and progressive?
So Mavenclad has not been studied in someone who is 70, right? We didn't do clinical trials, the phase 3 trials. There are some ongoing studies right now. There's a trial called the Masters trial, which is looking at giving Mavenclad in people that are older, but that data is not published yet. Now, anecdotally, meaning my experience, yes, I do think it can work in that age group, but I can't point to data to prove that just yet.
Okay, thank you. In answer to that, none of the meds are studied after age 65, right?
Yeah, we have very, very little data that's class 1 data beyond 55, which doesn't mean they don't work. They do. We just didn't study them in that age group.
All right, next one, Patricia, again, who left a comment for me, now leaves one for you. Dr. Boster, I really enjoy listening to your presentations. I like that you use understandable language, which differs from trying to read a study. TV for keeping it, thank you for keeping it understandable. Thank you again, Patricia.
Thank you, Patricia.
One terrible bout when diagnosed at 29, after went on for 25 years with nothing. Was a regular runner, now at 67, my right foot drop and heavy leg is SPMS, never been on meds. Any benefit now to go on a med?
Yes. Yeah, I don't think it's too late. Not at all.
All right. And there's a person asking your opinion on Mazent, again, for over 62. And I think you answered that with the 72 or the 75. So it's probably the same answer.
Correct.
Right. All right. Go on it. That's the bottom line. You don't have anything to lose, right?
I think it's always important to discuss risk benefit, and risk benefit changes as we age, but it doesn't mean that it's not worth the while having the conversation. And I find time and time again, we can find a medicine which is safe for you, which can help slow things down. So I'm a big proponent. Absolutely.
Dr. Boster, again, you're my sweetheart. There you go.
As always, thank you for giving up your evening. I want to thank MS Visa News.
Say that.
Stuart, thank you for inviting me to be on and to have this conversation. I want to thank Sandoz for sponsoring this and making it possible. And I absolutely look forward to being back here in a couple months so we can do more of this together.
Thank you again, and everybody have a great night. Bill, cut it. Thank you.